Welcome to the Checkout. My name is Alex Kasich, Senior Reporter for Modern Healthcare. Today, I'm fortunate to be joined by Dennis Matheis, who took on the role of President and CEO of Sentara Healthcare on September 1st. Dennis was the President of Sentara Health Plans and Executive Vice President at Sentara Healthcare over the past 5 years. He now oversees the nonprofit health system's 12 hospitals in Virginia and Northeastern North Carolina. It's 29,000 employees, 1,300 physicians, and a health plan that serves more than 950,000 members. Thanks for joining us, Dennis.
Thank you. It's great to meet you, Alex.
Yeah, thank you so much for taking the time. I wanted to get a little bit more insight into your role on the health plan side. I'm curious how that will inform the position of CEO going forward, and how you'll adapt and how that experience will help shape your governance and expertise there.
Sure. So I guess I'd start with I have 27 plus years of experience in healthcare, and I've actually worked on both the provider side as well as the payer side of the house in previous lifetimes. And so I like to think that I bring enough of a balanced perspective in terms of both of the key operations of Sentara as we move forward. I think the opportunity for me in this role is really a couple things. One, certainly as we move forward as an organization, continue to improve the member and patient experience and becoming more consumer focused as an organization is going to be important for our continued success at Sentara. And I think my experiences both on the health plan side and in previous roles really have provided me with a lot of learnings around making sure that we move forward as a customer-focused organization. I think the second thing is I'm blessed that I've inherited an incredibly strong team here at Sentara, and so we have a really strong and deep bench of leaders in the organization, and it speaks to the success that Sentara has had over the years in terms of our quality outcomes and our performance. And so I've got in one way, I've got a great role in terms of inheriting the previous success of the organization. And now it's harnessing that as we move forward and again, try to start to really evolve more towards a consumer-driven organization. I think the other couple of points I would make is one, and my wife was an ICU nurse for 20 plus years. And so I do have both a passion and a fond experience of what it is to be a nurse in a high acuity care setting. And so I really appreciate, it makes me appreciate our team members in our 12 facilities and the work that they do day in and day out in terms of taking care of all the patients that we service throughout the course of a year. Secondly, I think in terms of what I bring to the table is a notion of pushing decision-making down into the organization. So one of the things that I have done in previous roles is really try to engage leadership deeper in the organization and push decision-making down. And that's going to be incredibly important for our continued journey as a consumer-driven organization. I and my team, quite frankly, don't interact day to day with our members, with our patients, as often as our field leaders do. And so pushing that decision making down and putting it in the hands of people that are closer to our customers is a key element to how you start to really move an organization to become more consumer focused.
And one thing that I've heard from health systems that have an integrated health plan is that affords them unique opportunities. One of which, I've heard on the risk-based contracting side, with that data, it allows you to pursue different types of value-based contracts and arrangements, and under a capitated model and other payment methods. So, could you help explain what opportunities being an integrated health system provides?
Sure. I think it's on several different levels, and I think the first is having both a payer and a provider under a single roof really allows for trust to be built and creating a more of a common dialogue between the two sides of the organization, and that's incredibly important to be able to advance payment for value as you move forward, and both engaging with your patients as well as payers, other payers, and ultimately employers. So I think an example of that, we have Sequin, which is the Sentara Quality Care Network, and it's a broad group of physicians that are encompassing both our employed physicians as well as community physicians. And if you go back 7 years ago, there was no other payers that were willing to contract with Sequin on a value-based perspective. And so having a financing arm in Optima Health, we were able to do that, one. And then secondly, engaging with Sequin and with large employers in the community. So think the city of Virginia Beach, the city of Norfolk, several others, engaging with them and actually bringing doctors to the table, employers to the table, and actually discussing how do we actually move the needle on both quality and affordability through Sequin was incredibly valuable. And actually employers stepped up and actually helped support the gestation of Sequin, the infrastructure that we needed to make sure that we could drive those improvements. And over a 5-year period, they've really shown significant proof points. And so one, patients that go through Sequin with these employers typically rank somewhere in between the 90th and 75th percentile on HEDIS measures. Secondly, when you look at healthcare trends, the patients that go through Sequin for these employers have experienced below national average trends over the last 5 years. And so having that, both the financing and care delivery under one roof and being able to engage with the employer market in a different fashion, and then tied to that was benefit design. So actually tweaking benefit design to engage patients and members in a different way so that they would engage with Sequin physicians more frequently and in a more trusting manner actually help drive those outcomes as well, Alex. And so it's a great example of why we believe the model that we have here at Sentara is one that we're going to continue to leverage as we move forward into the future.
I wanted to touch on an issue that's affecting everyone across the healthcare industry, on employment and staffing. And I saw an announcement from Sentara recently that it would boost pay for most of its employees that work at Sentara, and will also offer reimbursement for various types of benefits, such as adoptions and infertility care, as well as increased PTO, parental leave, and other benefits. How does this play into your recruitment or retention strategy, and what are some of the long-term changes this staffing disruption has brought to your outlook there?
Yeah, that's a great question. And, it's interesting if you, and some of this is right out of the pages of your magazine, as around the shortage of staffing that we're going to experience in this country in healthcare over the next decade. And so as you look at the nursing shortage, which is, depending on what you see, somewhere between 300,000 and a 500,000 nurses that we're going to be short nationally through 2028. And then you stack that on to another roughly 500,000 other associated allied health professional shortages in other areas. And it's a really scary thing in terms of how do you staff 12 hospitals, the associated clinics that go with that. And so we've certainly in the last 2 years tried to get ahead of the curve in terms of market wages and compensation and benefit design for our team members. And I think to a degree that's been very successful for us in terms of stabilizing our workforce as we move forward. I think as we start to evolve over the next several years, several things are going to happen. So first, looking at how we create better workforce flexibility for our team members is going to just become more and more important for us in terms of how we think about shifting, how do we think about skill sets and matching it up to nurses' preferred areas of work and trying to make that a better match over time. I think secondly, the notion of actually getting people to practice atop a license. It's a critical thing for us in healthcare as we look across all of our highly skilled labor forces. How do we get them to actually practice at top of license? And that would include physicians, nurses, you go down the line of professionals. And so it's both thinking of new ways to deliver care. And so how do we leverage other team members to actually help in the care delivery process, to free up those members to actually focus at their top of license, and then leveraging technology as well in terms of trying to create smoother, easier, more efficient workplaces for our team members as we move forward. And then the next area is really around, we're going to have to do a better job of creating desire for people to jump into healthcare careers. And so that really, I think, is going to force us to start engaging at the high school level and actually educating kids on the benefits of a healthcare career and what that can do for them, and then creating the career pathing within our organization and in partnership with others to help people evolve their careers as they move forward. One of the, I went on a listening tour prior to my start as CEO at Sentara, and I visited all 12 of our health facilities, among others. And it was struck me that I heard from a number of our nurses what they started out as something else before they got their nursing license. So whether they were a nurse extender or a lab technician or other support roles, went back and got their education and became nurses, and they now have a very wonderful career in front of them as caregivers. And so we need to do more to foster that as we move forward as an organization, and it's something that we're going to have to take a longer term view on as well, because just I would say the things that we've done in the near term were critically necessary to stabilize our current work situation, but we're going to have to do a lot more, as I've just kind of laid out, in the long run to improve our staffing levels over the long haul.
I wanted to follow up on one thing there, and you hear this a lot, just allowing caregivers and physicians and advanced practice practitioners to practice at the top of their license. And that, I imagine, is somewhat difficult for a system that's spread out across multiple states. You have different state laws regarding scope of practice. You have other regulations there, and just unique opportunities within, depending on how your health system is set up. So what does that look like in facilitating this ability for nurses, advanced practice practitioners, and other clinicians to practice at the top of their license?
Yeah, I guess I would point out several things that I think are opportunities. So one, certainly you hit on one of them, which is how do we cultivate and continue to evolve the legislative and regulatory bodies to allow for more consistency to get us to top of license across all of the different geographies that we serve. That's certainly an opportunity. Secondly, it is about again, I mentioned leveraging technology. So I'll give you an example. Today, our physicians, unfortunately, would tell you they spend 2 hours on average documenting the patient care and everything that they have done during the course of their workload on a day. That's a lot of time. And so the promise of the EMRs and other things, I think, still holds. But the way we have constructed it to date is actually sucking a lot of administrative time out of those caregivers rather than actually having them put their cognitive time in taking care of patients. And so, there are nascent technologies that are being developed to be more intuitive, so to actually help with that documentation in a way that doesn't tie up caregiver time. So if you can free up an hour of time a day for each of our practicing physicians and then the associated nurses that go along with that, that's an incredible boost to availability of highly trained people to actually care for patients and others.
And this dovetails with the staffing end, but the mental health crisis that's hit caregivers because so many of their peers are leaving, they're going to have to pick up more slack, and that's just unsustainable for many in the practice. You have others that are retiring, and the burdens of the COVID-19 pandemic has just had an immense toll on the well-being of your employees, but also on the patient-facing front. More people are presenting to your emergency departments, I imagine, with more severe mental health issues. So how are you attacking this issue both internally and externally as you treat higher demand?
Yeah, it's a great question, and not a lot of easy answers tied to the question. I think the internally, one of the things that we did about a year ago now is, and it was one of the benefits of actually being both a payer and a provider, in looking at behavioral health needs for our team members. We decided to actually deploy behavioral health team members in our hospitals. We actually created safe spaces for nurses to be able to go visit behavioral health team members in our facilities, and actually, put the care to them when they needed it and where they needed it in our hospitals, and relabeled some of our own traditional labeling to take some of the stigma off of actually going to do that. And that's been quite successful. A lot of good data saying that it's been very helpful to our team members. And so that is, it's a good first step in terms of helping our team members on their journey to help recover what they've been through over the last 2 years. And, to that point, I just say, the stats are pretty ugly. We've lost 100,000 nurses nationally under the age of 35 that have left the field over the last 2.5 years because of the stress. And so there's more work to be done there for sure. I think externally, I think what the COVID crisis has actually exposed are long simmering issues with regard to access and underdiagnosis and undertreatment of behavioral health issues. And so certainly how it's manifested itself for us is you see patients in crisis showing up in our EDs, and there's not a good opportunity to actually put those patients in appropriate settings to seek their crisis care. And so it creates log jams in our EDs, and it's not ideal for treating patients in an ED. And so that's created a number of difficulties, both for the patients and for treating medical conditions as well. And so we've done several things that in the short term to try to address that. We put a team together to really focus on this back in July of 2021, and really trying to attack the ED throughput issue. And so in some cases, we've remodeled some of our EDs to actually create designated behavioral health space that allows us to free up some staff, and so you're not in a one-to-one situation in all of those instances when our people are in crisis. And then we've secondly started to really pivot towards working with outreach from a technology perspective. So think virtual care, and really trying to move the problem sooner into the diagnosis for patients. And so trying to get to people before they have crisis, and then actually don't end up in the emergency department. Longer term, we're going to have to really, I think it's going to go evolve to public-private partnerships. And so I think certainly the state, so in our case, the state of Virginia and the state of North Carolina are going to have to play a role in this crisis. But I also think that we're going to have to come to the table with solutions as well. And I think those are going to look at, how do we, beef up long-term the number of behavioral health individuals in the marketplace, whether that be psychiatrists or psychologists or others. And then I do think leveraging technology, in this case virtual care, has a ton of promise to create better access, again, before people are falling into a crisis mode. And the last thing I guess I would say there is, I think for us, it's also, we're asking the question now, do we have to think differently about the care continuum with regard to behavioral health? And then how do we actually embed it more in our primary care practices in a way that gets to it again sooner rather than later in terms of a patient's diagnosis and opportunity? And certainly for individuals with chronic diseases, behavioral health issues typically go hand in hand with a lot of folks with chronic care issues. And if one goes untreated, the other is going to suffer as well. And so we do see it as a responsibility of ours to come up and figure out how we can do a better job there.
Well, Dennis, thank you so much for sharing your time, perspective, and expertise with us. It's been a pleasure.
Alex, it's really nice to meet you too, and have a great day.
Thank you, you too.
Thanks.